now turn to Dr. Ayana Jordan, who is the endowed Barbara Wilson Associate Professor in the Department of Psychiatry, a addiction psychiatrist, and Associate Professor in the Department of Population Health at New York University Grossman School of Medicine. Dr. Jordan?
Wonderful. It's really great to be here talking about the cultural considerations for increasing access to care. Next slide. Anytime I speak, I really just like to ground us with a land acknowledgement. I'm in New York City, and so I really want to honor the memory and legacy of New York City's original people. That's the Lenape people as defenders and stewards of the land. I do believe as researchers and physicians and other clinicians, it's our duty to acknowledge that many of the institutions where we work in or conduct research on are indeed on Native land. So I give thanks to the indigenous people of New York City. And then finally, land acknowledgements do not exist in the past tense or historical context. Colonialism is a current ongoing process, and we do need to be mindful of our present participation and thinking about how does our research or clinical care really propagate having political control of others. Next slide. I don't have any financial disclosures, but I do receive funding from these organizations. Next slide. All right, so when we're thinking about how to increase access to care and what are the cultural considerations, we have to really consider the root factors. And I know the audiences here are well versed with these issues, but really wanting to just call out how our public policies, really inequities in the social determinants of health, othering of people with central nervous system disorders, stigma and racism really do limit access to care, whether consciously and unconsciously. And one example that I like to give as an addiction psychiatrist is really thinking about how our current methadone policies really do impact care, right? So thinking about how people have to wait a year or 2 years, respectively, before they're able to get access to 14 or 28-day doses of their medication really does limit how people are able to care for themselves. And so how can we really be advocates and be part of the conversation to make sure that people are able to really take care of themselves and not make it harder? Next slide. One of the things that's really important in terms of the lab, the Jordan Wellness Collaborative, my lab, and really consulting with other groups is really taking an assessment of the treatment and research culture and thinking about ways that you might be unconsciously creating barriers. So one of the things that I always say, and I love this sheet from dismantlingracism.org, is really looking at the culture that you exist in. So is there a fear of open conflict? And what I mean by that is that oftentimes white discomfort or white fragility really limits discussions about how research or clinical care can be provided in a ways that value other conditions or other types of views. Another thing is individualism. Is someone really focused on just the person itself without thinking about how community might be involved in care? So how does that promote access? Next slide. Next slide. So if we want different results, we must do things differently. And I love this work by Helen and Hansen, where she talks about, you can click, really looking at the master narrative and thinking about, click please, how the way that we center whiteness has to really be decentered so that we're able to focus on diverse cultural views. Next, please. And you can click again, you can just click. Right, really thinking about the sources of racial inequalities in care and not just focusing on the social determinants of health, which is important, but looking upstream to structural racism and thinking about how does that uphold the master predominant narrative. And then finally, looking at research participants and clinical patients as wonders to behold as opposed to problems to be solved. So really thinking about people who have been able to take care of themselves in oppressive structures, how have they been able to do so and how can we strengthen those factors? Next slide. So really looking at community-informed expertise, and you can click all the way through, realizing that voices from historically excluded communities must be included in narrative solutions, understanding that we have to develop leaders, right? Leaders just are not born, but we have to pour into community leaders. And then really thinking about how health programs really meet the needs by removing current and historic barriers. So I want to just talk about two examples that will go into more detail in the Q&A. Next slide, but really thinking about one of the projects where we're providing addiction treatment in Black church settings for Black people with alcohol use disorder. Next slide. And another project that we're doing now where we're leveraging digital technology to really increase access to medication for addiction treatment in Black and Latinx churches. So I look forward to discussing more during the Q&A. Thank you.
Oh, that was powerful. Thank you so much, Dr. Jordan. Agree with you on the resilience factors. Looking forward to the discussion